birthday. Everybody just moved those tickets up a couple weeks, and her entire family gathered, 6 kids, spouses, grandkids. And it was a really amazing 3 or 4 weeks of her going into renal failure. I took many opportunities to take students with me because the love in this house was palpable. It was just an incredible experience to be with this woman who was still in charge of her decisions. The symptoms of renal failure can be managed, in her case especially, very easily. And she did not have the fluid problem, so even though the fluid problem can be managed too, for her it was very, very simple. And she remained just a really active part of her family until just a few days before she died, and just was very, very comfortable. And that really taught me that if you help prepare people ahead of time, you know, there are choices, there's a meaning and importance to the choices that we as the docs and the caregivers have no idea about. I had no idea that being able to control timing and get her kids there was important to her. And so, but in talking about these things, that's where we provide people opportunity and empowerment, so that despite the fact that we can't change the fact that they're going to die, we can keep them in control of what this time is like for them. So that's, you know, palliative care is not about dying, it is about living. And it's about living as well as you can until you either can't or don't want to. In which case, the rest we make, you know, it's all about doing it the way you want to do it.
This is a quote by Dame Cicely Saunders, and it's on a plaque outside the first hospice that was in England. "You matter because you are you. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die." And that was a building with a feeling of being alive and a feeling of life and love. And that's what we invoke when we talk about palliative care. Thank you.
So we have purposely left a lot of time for questions and answers, and we will understand if there are folks who want to leave, so don't worry about offending us. But we would like to try to address what's on your mind. And
please use a standing microphone available so everyone can hear you if you have questions.
Thank you so much. Beautifully done, as always. I say thank you so much and beautifully done as always. A question, you used the word many times, aggressive care. And my understanding, right or wrong, with hospice, it is non-aggressive. We tend to indeed control the discomfort, the pain, but when it comes to aggressive preventive care, it was my understanding that's not who we are. Help me, please.
Well, I might take that.
I think one of the reasons why the term aggressive is falling out of favor in the language that we use in the hospital is because we can be aggressive at managing symptoms, that it can be sort of a fortitude of our intent. And when we talk about aggressive care, I think we're usually invoking physically burdensome care. So sometimes we'll pair the term aggressive burdensome care, meaning being on a ventilator. But I think you're right for what you're describing, that the philosophy of hospice care is non-burdensome means at achieving goals. And in terms of aggressive, in disease-directed care, it doesn't usually apply when we think about hospice care. But it depends on how you use the word.
And I will say in the medical community, aggressive means life extending, always. I mean, they don't really talk about aggressive symptom management, even though we talk about it.
I was going to say, like, I'm in meetings sometimes and the team will say, do you want us to be aggressive? And what's the opposite of that? We'll be laissez-faire. You know, we'll be, let's be slack. you know, and so the language we use means a lot on what people choose. So I think that's one of the words that you might be hearing us sort of shifting away from.
Right.
Thank you.
Hi, again, thank you very much for doing this. It's very good for all of us together. Home or hospital, disease-directed or life-quality-directed? Not sure I've got the right name for the two paths, but can you help me with that? If you decide you want to go home, can you also have the disease-directed approach too?
Every case is different, and too often, I think, we feel like the life extending option is sort of presented, and the other option is sort of like, oh, we'll just keep you comfortable, and yet both paths are equally active, maybe even aggressive, and there are circumstances where you can actually be very aggressive in terms of life extending care at home, and if there is something, you know, it's very useful to say, okay, this is what when these conversations happen, it's not like, let's make a deal, do you want box A, B, or C? It's, tell me what's important to you so that I can help you understand your choices relative to what's important to you. And it's a dialogue. So somebody may say, gee, I really want to try to live as long as I can, like our second case, but I want to be at home to do so. And that's what we did with his care going forward. On the other hand, somebody might say, like in our first case, I want to do everything I can to knock this tumor down so I can live longer. And so that's what palliative care pursued.
So the choice can be made home or hospital for either approach that you want.
It depends upon the disease process. It depends upon where somebody's at.
Yeah. Okay. Thanks.
I was wondering what your experience has been in the role of palliative care and hospice with how you deal with patients who have dementia, who you don't have much opportunity to get to know because they're in usually a very late stage of their dementia. So anything you've learned about how to deal with that type of a situation?
I'll speak to my role in working with people at a time of crisis, which is when they're admitted to the hospital. And I think dementia is a very special disease in that it's a terminal illness that will progress and has specific complications that are fairly predictable as it goes along its course. Someone may die of another illness before that, but if dementia is to follow its full course, it involves losing physical function as well as mental function. And some of the side effects of that are difficulty swallowing, aspirating, having food go down the wrong way, developing pneumonia, and recurrent infections. And the thing to know about what the kind of medical directed care is that we really need to know what an individual's goals are before we can recommend a plan of care. And some people's goals, as they are nearing the end of their life, are to have medical therapies aimed at living longer. And there's a point in someone's life, and it's a very individual point, where people's goals are not to live longer. In the case for patients with dementia, it's usually family members that are acting as surrogate decision makers and making decisions for the patient, but the person themselves may have an advance directive that gives some guidance. And those types of advance directives can give an idea about how important is quality of life and in what situations would living longer be a goal of medical care. My grandmother lived to be 99 and a half, and she had pretty advanced dementia for her final years. But at 91, she was driving. And she used to say, she was ready anytime. You know, she's like, I lived a good life. And she used to also say, it's not good to look younger than your age because people expect so much of you. So everyone expected her to help out at the clubhouse and help clean up after dinner. But she really was a very independent woman, and it was a very tragic thing to see her in the final stages of dementia. And she was living in a nursing home at the end, and this was not in this state. But we had a very good living will, and I went through it with my mom and my aunt, who was a nurse, to say that her goals of medical care are about being comfortable. That her goals at that point in her life were not to have medical interventions aimed at living longer. That if she were speaking for herself, she would say, I lived a good life. If I get sick, just keep me comfortable. And her life had to end some way. What's a better way than it's going to be an infection? And so we had a plan that the next time she was seriously ill, our goals were about keeping her comfortable. And she went into an emergency room, and no one asked about her goals of care. And they looked at her living will that said, she wouldn't want to be on a ventilator, she wouldn't want CPR attempted at the end of her life. And they started antibiotics. She had a kidney blood infection. It was tragic. And my mom said that 2 days later, she said, I missed our chance, didn't I? And she said, I felt like I was asking them to kill her. For her to advocate and say, don't treat the infection, that's what a family member feels like they're saying. And my mother it was so hard the last 6 months that she had her own stuff, which was, will this ever end? This is my mom, and I don't know that I can do this much longer. It was sad. And I told her I thought it was malpractice in this day and age, that they would deliver antibiotics without asking what her goals of care were. My dad plays golf with the doctor, or a doctor in the hospital. It's a small town in Georgia. And that doctor said it was ethically inappropriate to not do antibiotics. And that's not true. And healthcare, we're here to serve people's goals. And she did die 3 months later comfortably. We enrolled her in hospice. And I felt like that's kind of a good stamp sometimes that makes people think twice.
That's exactly right.
But it was sad.
I just want to make I happened to be pinch hitting for the ethics team in the hospital one day, and I got a call about exactly this case of a gentleman in this case, but the doctor called me and said, this family does not want me to treat this man's pneumonia, but this is a completely treatable problem. We can fix this. And the situation was advanced dementia, very clear goals of care. The family wanted comfort and did not want his life prolonged. And she was really having a hard time because this was a fixable problem. We can fix this, just like the person on the golf course. And I was struggling to try to think about how to talk about this. And I was raised in Southern California, so the metaphor of a freeway came to mind. And I said, look, we're all on the freeway of life. And periodically there are off-ramps. And normally as a doctor, what I do is I stand in the way and I keep people from getting off. But if the person wants to get off at that exit and looks down the highway and doesn't really see they don't like what they see down the road, it's okay to step aside and let them off. And that's not the same as pushing them over the guardrail. And that, helping docs and others see that allowing a natural event to occur rather than letting somebody go further to die of end-stage dementia is okay if that's what the person would have chosen for themselves, or what, in the absence of those kinds of directives, what we feel would be best for that person. I recently had a gentleman with pretty severe dementia that was pretty rough on everybody, him and his family. And he totally unexpectedly developed an infection that was very, very serious, and we knew it was pretty serious right away. And I thought of Ursula's picture of the paths going together. And I said to his daughter, I think this is his final illness. And I think the outcome is the same no matter what we do. But we can keep him where he is and control the pain and keep him nice and comfortable. Or we can send him to the hospital where he will get a CAT scan, have surgery, may or may not survive surgery. But the outcome is likely to be the same just because he was so debilitated that, he could die in the operating room pretty easily. And I really did feel that he wouldn't survive, survive to go back home anyway. And the family talked, and they were very clear that, for many months they had really been on a comfort-oriented track, and that sending him to the hospital to do all that would serve no purpose, and that and they had the most lovely visitation and filled the room with family for about the next 36 hours, and he died a really peaceful, comfortable death. So I just want to get back to the original question, which is asking about, because we've been talking about acute illnesses that happen to people with dementia. And honestly, people, not everybody with dementia has those opportunities, those off-ramp opportunities. And things that I will say I've personally learned is timing is very difficult to predict with dementia. So people can have end-stage dementia for years before they actually die. The things that trigger dying in dementia are the inability to eat. And if somebody elects not to have artificial feeding, that is often the first step. Interestingly, though, we know now from studies that when somebody becomes unable to eat, placing a tube and feeding them through the tube, they don't live any longer. Which means that the inability to eat is a symptom of advanced dementia, of brain failure, if you will, as opposed to the cause of somebody dying of dementia. So the course is very unpredictable, very, very difficult to predict. And then the other piece is, I just don't think there is a disease that's harder on a family, and many of you probably know that the person who asked this question is an expert in this area. And it's very, caring for a loved one who has become a different person is a very, very difficult thing. And people's ability to do that work vary, not only people's individual qualities, but also just having the social circumstances in terms of assistance and that kind of thing. You qualify for hospice with having a prognosis of less than 6 months. It is very difficult to tell when a dementia patient is at the last 6 months of life, because many of them have about a 50-50 chance of dying in the next month for the last couple of years of their life. So it's very difficult, and there really is a difficult burden, and the whole, a lot of families can kind of get up for an intense period of caregiving that's going to be relatively short. It is very, very difficult to do it year after year after year. So those would be the two things that really stand out for me.
Quick question. Is palliative care becoming a specialty that people who are reaching their end of life or whatever should be seeking out? I mean, you guys, is it now a specialty at Fletcher Allen?
So palliative care is a medical subspecialty. It has a fellowship, and it has a board certification process. Physicians can become board certified in palliative care from many routes: internal medicine, family medicine, pediatrics, anesthesia, pain, and it is a subspecialty. Should you see somebody, there's a deficit, would be the word. There's a shortage of palliative care providers. And so we have the need is really, in terms of seeing a physician for palliative care, probably is outweighing the availability of the provider. I'm now the sole physician at Fletcher Allen who's specialized in palliative care, but I work with a nurse, Barb Siegel, who is worth 2 doctors, and so we're okay. But
I would just talk a little bit about, we talk about primary services, secondary services, and tertiary services. And the goal of us being involved in palliative care is we would like every physician out there to know some basics, some what I would call primary palliative care, some basics of pain management, some basics of decision making, some basics of the kinds of things that we've talked about today. Everybody should be able to do that. That's not a reality yet. I wasn't taught anything about palliative care in my training, and okay, I got a few gray hairs, but it really wasn't that long ago. And then there's another level, and then there's the tertiary level. And tertiary level care we tend to think about in medical centers. In palliative care, those aren't necessarily the most skilled people because they're doing a very different kind of job in a tertiary center. And so right now, absolutely palliative care is in its infancy as a specialty. We've only had board certification less than 20 years, right? And fellowships have really become plentiful in the last 10 years, but they're not able to produce as many specialists as are needed in this area. And frankly, the pioneers in this area are retiring. So Valmount and, you know, the people who really started this are, so, but it's growing.
Hello. So with palliative care, you have to have, I assume that you have to have death in sight at some point. I mean, I'm not too familiar with the field, but I expect you come across some patients who perhaps haven't really thought much about that and only really think that they're going to get better. So I was wondering how you address palliative care with those patients.
I thought you might ask about death insight in terms of physician and providers in the hospital, because I think there's also some denial in terms of what's happening on both the professional side and the public side. It's not an uncommon thing when I get consulted to help with goals of care of a patient in the hospital that the primary team might think that the patient or the family is in denial because death may be coming and they're not talking about it or they don't want to talk about it. And I think that we look at that denial is a defense mechanism and it can be adaptive. And I would say I have death denial because I don't feel like my life's coming to an end. And there's something about feeling that way that's very human. And it can also help support people to live well day to day. And so it's not always necessary to talk explicitly about dying to address palliative care needs. And people have a pace at which they cope. And so you look at what do we really have to talk about, and if this person isn't able or not interested or it's not helpful to them, that we don't have to talk explicitly about dying. And there's so much more of a message, especially being involved earlier on in palliative care, about a focus about quality of life. And that can be the relationship that we build. But I'll frequently dip my toe in because if somebody's not interested in talking about it, I don't want to ruin the relationship. And I don't want them to think that that's what I'm about, you know, end of life care. But I'll ask people, some people when they're as sick as you, they wonder if they're nearing the end of their lives. And some people say, no, I'm not wondering that. And then we talk about other things. And some people say, yeah, I think about that a lot. And I say, well, what do you think about when you think about it? And so it's about figuring out what's helpful for people to talk about and figuring out how urgent is that discussion to involve end of life. And if somebody isn't at the very end, it may not even be necessary to even talk much about it.
Yeah, I would agree. The key is sort of figuring out where somebody's at and helping them with whatever their issues are right then. And Barb Siegel, who both Ursula and I have worked with and is worth her weight in gold, you know, has a saying that if you support people where they are, they will move along on their own. And having been someone who, in my very younger days, used to think if I just argued hard enough, people would understand. Guess what? It does not work. And it's so interesting how you really can, and I learned this directly from Barb, you can plant some seeds about, you know, gosh, have you ever thought about, you know, I really hope this happens, I hope this goes well too. Have you ever thought about what you might want if it didn't go as well as we hope? And some people will say, no, I've never thought about that. And you go, okay, fine. But it's interesting how often I have heard people that I've planted that kind of a seed with, the next time, or maybe 2 times later that I see them, they come up with this idea as if we have never discussed it before. And I'm serious. And it was so interesting. It's like, you know, you just kind of, there was just a little suggestion that part of their brain might want to start thinking about this, and it does. And it's amazing. I mean, it really is. And, you know, when people become advocates for talking about something that really 2 days earlier they told you they didn't ever want to think about, it's really fascinating. So it's a gentle approach. It's supporting people where they are, letting people know that there might be something available to them to talk about if that would ever be useful to them. Years ago, I took care of a gentleman who had cancer. He was a physician, actually, and he had a laryngeal throat cancer, and he had just had a tube placed for feeding because he was having trouble swallowing. And I met him, and we talked a little bit, and then he sent his family out of the room. He said, look, I know how people die with this disease, and so do you. He said, I don't want any part of it. When that comes, you just knock me out. I said, oh, well, okay. I said, you know, I know you just had the G-tube placed, and right now your wife is grinding up, I'm not kidding you, steak and mashed potatoes and putting it through the tube. And I said, and right now that food is keeping you going. It's keeping, he had normal energy, he's playing with the grandkids, having a great old time. I said, but you know, there will probably come a time in the future where your disease progresses to the point where the nutrition is no longer having that effect. And at that point, maybe we might want to think about stopping that nutrition because the benefits may not be worth with the drawbacks anymore. And he was shocked, and this is an older physician, and he was really shocked at the idea that we wouldn't feed somebody right till the end of life. But we dropped the discussion and went on. About 3 months later, I was seeing him for a completely unrelated problem. I mean, it was related to his cancer, but, and I was leaving the room and he said something. I turned around and I said, what? He said, well, I was just thinking it might be time to stop the tube feeding. And I was really surprised because he was still really doing really well to my eyes. And I said, well, tell me more about that. Because I first started to say, oh no, you're fine, you know. But we had talked back at that initial discussion that, you know, it takes 6 or 8 weeks to starve to death. And at a point when your cancer is advancing and you no longer have time to be harmed by the lack of nutrition, there are a lot of good reasons that the lack of nutrition prepares one for a much more comfortable death. So he knew that. And so he said, I said, well, tell me more about that when he said he wanted to stop. And he said, well, you know, I really feel my energy waning. And he had a number of different things he had noticed about himself that I had not noticed. And I said, well, okay, that's what we'll do. And about 3 weeks later, he was dying. And if he had had the tube feeding still going, he would have had a lot more adverse symptoms that would have been very, very challenging to keeping him comfortable. And as it was, he really died a very, very peaceful, comfortable death. And that really taught me that if you give people information ahead of time, they can use it much better than we can, because I didn't at all anticipate that this guy was 3 weeks away from dying, and yet something in him told him that things were changing. And that's really such a wonderful thing, to sort of see that this person really did take control and know his body better than I could know it from outside.
We have time just for one more question, but I would ask each of you to fill out your survey and leave it in the basket at the door before you leave.
Hi, this is really 2 questions.